I'm Rod Rourke. I'd like to welcome you to this edition of the PRS Journal Club podcast with your hosts, Drs. Jordan Frey, Chad Purnell, and Dr. Shuja Shafqat. Please enjoy.
Hi, everyone, and welcome to the March 2017 edition of the PRS Journal Club podcast. I'm Jordan Frey, PRS Resident Ambassador from NYU, and I'm joined as always by my co-ambassadors Chad Purnell from Northwestern and Shuja Shafqat from Lehigh Valley. Today we have the honor of being joined by Dr. Nolan Karp, Professor of Plastic Surgery at NYU. Thank you very much, Dr. Karp, for joining us for this PRS Journal Club podcast.
Jordan, you're very welcome.
The article we'll now be discussing is Comparison of Different Acellular Dermal Matrix, ADM, in Breast Reconstruction, the 50-50 study. And this is a study out of Georgetown authored by Dr. Troy Pittman, Dr. Kenneth Fan, Andrew Knapp, Shelby France, and Dr. Scott Spears, the senior author. And as a quick reminder to all the listeners, all of the articles that we'll discuss today can be read for free on prsjournal.com, including an archive of all past Journal Club articles. So to begin with the article, as we know, acellular dermal matrices are derived from tissue-banked, deepithelialized cadaver skin and are processed to remove antigens and cellular debris to prevent a host reaction and also providing a scaffold for tissue ingrowth. ADMs were initially introduced in 1994, really for use in burn surgery. However, it was quickly picked up that they could be ideally used in implant-based breast reconstruction as they help maintain lower pole implant coverage and also are compliant enough to allow tissue expansion. And this was first really thoroughly described in breast reconstruction to provide infralateral coverage and support in 2005. Now, there are a variety of acellular dermal matrices available for use, and the first one was really Alloderm in 1994. And Alloderm's undergone an evolution in product development from an aseptic product that required multiple baths prior to use to a ready-to-use product that does not require refrigeration or rehydration at this point. They also have specially shaped and perforated products for use in breast reconstruction or any type of breast surgery. While well accepted, acellular dermal matrices, their use has been associated in some studies with increased complications, especially infection and seroma in implant-based breast reconstruction compared to total submuscular coverage. They also can add significant cost to the reconstruction, and for this reason there's a constant search for really ideal ADMs that can be used or improving upon the concept of ADMs. Dermacell is a newer ADM that has been recently introduced to the market, and it is decellularized and sterilized using low-dose gamma radiation, which is unique to the product. Dermacell can be stored at room temperature and can be used without rehydration or rinsing. So in this study, the authors have an objective of evaluating these two products and comparing the clinical performance and complication rates between Alloderm ready-to-use and Dermacell in implant-based breast reconstruction. To do this, they reviewed charts for 58 consecutive patients, which represented 100 breasts, from 2014 to 2015. The first 28 patients, or 50 breasts, underwent reconstruction with medium pieces of contour perforated Alloderm ready to use, while the next 30 patients, which represent 50 breasts again, underwent reconstruction with 8 by 16 centimeter pieces of Dermacell, which were fenestrated by the surgeons. All mastectomies were performed by the same 3 breast surgeons, and all reconstructions were performed by 1 plastic surgeon. The groups had differing numbers of nipple-sparing or skin-sparing mastectomy as well as tissue expander or direct-to-implant reconstruction according to patient factors and patient and surgeon preference. The authors then examined patient demographics, intraoperative variables, outcomes and complications that occurred within 90 days. And these complications included seroma, hematoma, cellulitis, mastectomy flap necrosis, and so on. One important outcome that they looked at was red breast syndrome, which was defined as a self-limiting erythema in the absence of skin edema or induration in an otherwise asymptomatic patient that's limited to the distribution of the underlying ADM. Cellulitis was defined contrastingly as whole breast erythema and edema that resolved with oral antibiotics. Looking at the results, the authors found no significant differences between the groups in terms of patient demographics, neoadjuvant or adjuvant therapy, the type or laterality of the mastectomy, And notably in the Alloderm group, 26% of the group underwent direct implant reconstruction, with 44% in the Dermacell group undergoing direct implant reconstruction. And there were no significant differences in terms of these reconstructions, direct implant versus tissue expander, or tissue expander initial fill or immediate implant volume between these groups. Looking more so at outcomes, they examined the time to drain removal and found that it was significantly lower in the Dermacell group at about 16 days versus about 21 days. And this change was still seen when the groups were divided by tissue expander or direct implant reconstructions. Also, they found that there were significantly higher rates of red breast syndrome in the Alloderm group compared to the Dermacell group at 26% versus 0%. There were no significant differences in terms of seroma, cellulitis, mastectomy, flap necrosis, or reconstructive failure between the two groups. So in their discussion, the authors hypothesized that the difference that they found in days to drain removal could be due to inherent differences in decellularization techniques, sterile processing, and packaging differences between the two products. Also, they note the Dermacell group has a sterility assurance level of 10 to the negative 6, compared to the Alloderm, which has a sterility assurance level of 10 to the negative 3. They also comment that the Alloderm ready-to-use product does come with a recommendation for a 2-minute sterile soak prior to implantation, which they did not implement in this study, therefore may lead it to not being quite ready to use, and can also result in the differences in drain removal and red breast syndrome that they found. So overall, I think this is an interesting study. It's not quite a case control study, but it does present two different cohorts with a more traditional ADM that more people are comfortable using, perhaps because they use it more in Alloderm versus one that is newer on the market. And they do find some interesting outcomes. So Dr. Karp, as someone who really is an expert in breast reconstruction and performs breast reconstruction very frequently, I'd be very interested to hear what you thought about this paper.
I thought this paper was fine. I think it's sort of like they used one Alloderm and then subsequently used, the other product, Dermacell. And, they're not matched. I think some things changed. They did more nipple-sparing mastectomy as they moved along. I think some of their results are not things that I see. We don't use Dermacell. We use Alloderm. And I don't think I can remember the last case of red breast syndrome I've seen. We used to see red breast syndrome with the older version, the freeze-dried, aseptic, not what's considered sterile Alloderm. But since we've gone to the ready-to-use current Alloderm that this paper used, I haven't seen a single case of red breast syndrome. The other thing that is interesting is that their time to removal of drains is much longer than ours. I cannot give you the exact time off the top of my head, but I would say that it's more in the range of 7 to 10 days. So I'm not sure what kind of drains they're using, how they're placing their drains, or something else that's resulting in the longer drainage. While I think this paper is interesting, our experience is not comparable. So I think they have to take it with a little grain of salt. It's also a small series, so it's hard to really make any judgments about this.
So I think, Dr. Karp, looking at this paper, really what they're trying to evaluate is which ADM, which product is best. But the question that even precedes that is, should ADM be used at all, or in what cases should ADM be used? So, and I think this is important for residents to pick up on as they're going out and will be performing breast reconstruction. In what cases do you use acellular dermal matrices, or what do you think are the indications in implant-based breast reconstruction for these products?
So if we're doing, direct implant reconstruction, we use ADM every time. If we have patients with nipple-sparing mastectomies, we're more frequently apt to use ADM because what happens is you have, your skin pocket, and if you try to do total muscle coverage, a lot of times you just will not get enough expansion to fill out the skin pocket. So, a nipple-sparing and a relatively larger patient will almost always get ADM. I'm from the generation, when I started doing this, we didn't have ADM, so we did muscle coverage. I'm very comfortable doing muscle coverage. I think that muscle coverage, if you make the pocket just right and you release it enough so you can get good expansion, it works just fine. And I don't know of a study that really compares ultimate outcomes in the end between patients that have had muscle coverage or coverage through the ADM for tissue expanders that really shows, one is really superior from the other. So there's a cost issue too. The ADM is $4,000 to $5,000 for a piece. And, and there was a time, particularly in the beginning, where we had increased infection and complication rates with ADM. I do not see them now. Our complication, the current versions of, we use the Alloderm that is used in this study, are very low. We've looked at this, and it's not statistically significantly different from muscle coverage.
I'd be interested, Chad, to see, what did you think about this paper?
I agree with everything that was said so far. I think it was just good to see a comparative study of two different products from two different companies. And I think at the end of the day, there weren't actually that many differences between these patients in outcomes that are really critical. And Dr. Karp, I actually wanted to circle back around to something you mentioned earlier. You talked about the cost of ADM, and it's pretty expensive. And there's a lot of pressure, I think, from hospitals and from insurance companies and from even the government for us to decrease our costs. So I was just curious what you thought the future of ADM use is going to be as this pressure increases.
I think that, it's going to be difficult. As surgeons, we're going to be looked at as at our total cost, meaning, the hospital cost, all materials we use, surgeons' cost, and, you're going to be at a big competitive disadvantage if you spend more money. So I think there's going to be tremendous pressure not to use these products. I think that you can do most breast reconstruction, particularly two-stage, without ADM, and I think that there is an opportunity for products that are less expensive and can do the same job. And I think there's a bunch of products that are out or coming out. I think Vicryl mesh just doesn't last long enough, but there are other products that are absorbable, last a bit longer and are much less expensive than ADM that I think over the next few years will come out to kind of fill this void.
So the other thing I wanted to know was that in this study, they pooled their direct-to-implant patients and their tissue expander patients. But I think we all realize that these are not necessarily the same patients. We all have different indications for performing tissue expanders versus direct-to-implant. And I want to know just philosophically what you thought of pooling direct-to-implant and tissue expander patients in the same study, and whether we should be separating these patients out whenever we do future studies of breast reconstruction.
Ideally, they should be separated out. It's a much cleaner study if you don't include them. They're really two different groups of patients. But, I think for the purposes of this study, it's fine. I think the later group had a higher rate of direct implants. But I think, generally speaking, studies are better if their patient populations are more pure and homogeneous. So if you're doing two-stage, comparing two methods of two-stage as opposed to it definitely muddies the water a little bit. I don't think it made much of a difference in this study based on the factors they were looking at, but I think ideally it would be better not to include TE and DTI in the same study.
Shuja, what did you think about whenever you were reading this article?
I personally like the synopsis they gave about red breast syndrome. I think in my 3 years in plastic surgery residency so far, I've only seen it once or twice. I do think that the 90-day analysis period was good. We saw in some of our previous articles that surgical site infections and some of these other complications are happening in a more delayed fashion outside of the immediate period. One thing I did want to ask was, they state that the Alloderm ready-to-use, which is what we use at our institution, is packaged in preservatives, and those preservatives could be causing more red breast syndrome or more seroma, possibly leading to later drain removal. Do you feel that Alloderm versus the Alloderm ready-to-use makes a difference? And do you think that if they had performed the entire 2-minute soak that was recommended, that would have an effect on their results at all?
We soak our Alloderm in triple antibiotics, which is vancomycin, bacitracin, and gentamicin. We don't soak it long. It comes in this little sheath, and we just put some on, and, it sits for a few minutes. So I think that, may help. But this Alloderm is much better than previous versions of Alloderm, and we've had very low complication rate and very few problems with this Alloderm. And we were people that actually wrote a lot about having problems with Alloderm. I think it's a very good product, and I think other than the cost, we're very comfortable with this product.
Dr. Karp, this is Jordan again. Another question for you. This is a bit of an aside, but in the paper, the authors cite the 2015 Cordero paper, noting that they prefer to perform direct-to-implant reconstruction or to get an implant into patients who received neoadjuvant chemotherapy or those with absolute indications to undergo postoperative radiation therapy in an attempt to minimize postoperative complications. Again, I think this is an important and tricky point for residents to kind of understand about the sequence in these patients who are expected to undergo adjuvant therapies. What are your thoughts about this preference, and what do you like to do?
I don't really use that as a factor. I think we do more DTI than they do, and I don't think that that's something that I do or that we do here at NYU. I think we treat the patient as a patient, and I think there is some literature that says that patients who have radiation do better with ADM. I can't say that I've necessarily seen that or not, but I can also say that I don't think we've looked at our results and made that determination. So it's not something that we really do.
Thank you, Dr. Karp. That was an excellent discussion, and I think with that, we'll end our discussion of this article. But remember, everyone, to tune in to the other two articles that will be discussed on this month's podcast, as well as the PRS Journal Club podcast that will be broadcasted every month. Also, don't forget to participate in our monthly Twitter #PRS Journal Club, where we'll be able to interact directly with this month's selected articles' authors. Thank you again, Dr. Karp, for joining us.
You're welcome, Jordan.
Join the PRS Journal Club. Read the monthly picks and classic pairings on PRSjournal.com. Discuss with the authors on Twitter @PRSJournal and listen to the podcast.